The NHS is overloaded and at breaking point, if not already past the breaking point. Clearly, what we're doing today doesn't work. There are, as humans, we are more metabolically dysfunctional. So in other words, we're fatter and more diabetic than we've ever been in human history on a per capita basis. And it's getting worse. That's despite decades of innovation, so-called innovation on all of the inputs to healthcare. Whether it's the technology that we use, whether it's the drugs that we prescribe, the care models, the beautiful hospitals, the insurance that gives better access. I mean, I say this a lot in other, venues and podcasts, but we've improved everything that's involved in the provision of care, yet our outcomes are increasingly worse.
Welcome to the HealthBeats podcast, brought to you by the inaugural Abu Dhabi Global Healthcare Week. The HealthBeats podcast series is your window into healthcare industry news making headlines and the role of Abu Dhabi and the UAE in unlocking global healthcare momentum. We'll be giving you insights on the future of the global healthcare sector and Abu Dhabi's contribution to it. I'm your host, Lara Satrakin, and in this week's episode, I'm joined by Ali Hashemi, co-founder and CEO of Metabolic, in a conversation entitled, "The Future of Digital Health Isn't Digital, It's Human, Unlocking the Power of Hybrid Healthcare." Ali, welcome to the podcast.
Thanks, Laura. Happy to be here.
Ali, you've said that the future of digital healthcare is actually human. What did you mean by that?
That's a pretty deep conversation. I mean, we've been working in the healthcare space for quite a while. And initially that started as a very traditional, old school kind of hospital that we were building. But more recently, my co-founders and I have been building what's termed a hybrid healthcare model that is both digital and physical. So the human plus the machine. A lot of the conversation around what constitutes the future of medicine has been focused around purely digital efforts to improve care, whether that's improve access, improve management, improve efficiency. And lots and lots and lots of VC dollars have been poured into building apps and tools and AI and so on to tackle various sort of endemic problems within healthcare. We always kind of felt that was not going to earn the right to win, especially in our domain, which is metabolic health. When you're thinking about metabolic health, you're talking about patients who are diabetic or pre-diabetic or overweight or obese. And in the context of these kinds of patients, it's a very high touch journey. It's a very high burden journey on the patient. And so the notion that you can digitize and engineer the humans out of that process is nonsensical, right? You simply can't. It's not even fathomable that you can take the humans out of the equation. So then the question becomes, okay, well, all these digital tools, as they evolve, how can we put them to best use? And through what channels do we use them? And so I think where we landed was, all of this innovation in digital health, whether it's the hardware itself, wearables like the fabulous Oura Ring, to CGM devices, to your Apple Watch, whatever it might be that you're wearing, to the apps that have, more ubiquitously enabled us to track things. How do all of those tools in total, as part of a holistic system, actually empower the humans within the system to be better versions of themselves?
So digital health, a lot of what we hear about is tracking wearables, knowing your numbers, so to speak. So how does hybrid health look through the metabolic lens?
So hybrid health helps you figure out the so what. What do you do on Monday morning at 8 a.m.? Let's say you've been tracking your sleep, you've been tracking your blood sugar, you've been doing labs regularly, and you've identified that there's a problem. That, I know my sleep is off. I know that that's caused high cortisol in the morning when I wake up. I know that that's causing high, sugar spikes. I know that my diet's off. I know all these things, and I'm overloaded with data. We've already gotten to a point that most of us we're overloaded. I mean, we just cannot sift through the data that's already being produced by our various wearable devices and our apps and so on. And so hybrid healthcare is giving you the so what. It's okay, well, that's the baseline or that's the input. Here's a care plan and a therapeutic protocol to allow you to achieve an ultimate objective.
And that's what comes from the human.
And that's what comes from the human. The human ends up being your translation partner. In other words, the individual or group of individuals who help you make sense of that data, to take that data and translate it into a so what. This matters. Don't worry about that. This is super concerning. This is a bit of noise. So helping you as a patient understand contextually what's important and what's not important, but then helping you figure out what to do about it, right? Because there's no point in tracking everything if you're not going to achieve a better outcome. And the outcome should ultimately be our currency by which we measure and judge our healthcare systems and how we pay for things, which we're nowhere near doing that. I mean, there's been a decade and a half of really interesting work done by, I've got a book back here by, folks that are part of the genesis of the conversation on value-based medicine. And still to this day, there's not a lot of value-based contracts that govern the way care is provided. And providers, by and large, aren't really tracking and reporting KPIs that they hold themselves accountable to.
I want to talk about that. And I also want to know what books are on your shelf because they all look really interesting. But you talk about all this. And the first question in my mind is, are there certain conditions or certain patients that are going to benefit most from this? There's certain fields of medicine that it's just going to be transformational for the patient experience and their outcomes if they can blend computer and human wisdom for their care.
Yeah, absolutely. I mean, we started tackling diabetes, first, because out of all the pools of patients, diabetics probably produce the most amount of data per person per day, however you want to measure it. They're constantly tracking. In the old days, they were doing the finger prick and tracking their bloods through that. Nowadays, there's a CGM, which produces a lot more data. We give all of our diabetics now an Aura ring, which helps us track their sleep staging, their daytime stress. Aura has just released a resilience score. Connected weight scales, connected blood pressure cuffs. So when you're talking about diabetics, because diabetes as a root metabolic dysfunction is ultimately connected to a wide range of related comorbidities, that's where we thought we would get the most impact in tackling a particular disease process with a hybrid care model.
So data-rich diseases, in a sense.
Correct.
Now I'm going to catch you. You said you started your work as an entrepreneur in sort of normal standard issue hospital, but it wasn't quite that. Your last venture was Continuum of Care hospitals, which is already a big difference from what we usually experience. And help us understand that. What is a Continuum of Care experience, and how does that potentially shed light on other ways of taking care of patients?
Yeah, good question. When I said it was more traditional, is that there was not a lot of tech involved in that care model, but it was an evolution that really elevated the Abu Dhabi ecosystem. It brought a lot of value to patients and their families. So just to kind of reframe it, back in 2011, 2012, I was a management consultant leading the healthcare practice for one of the large firms regionally, and there's a lot of gaps. Like when you're a management consultant, working with a wide range of clients at a very high level, you get to see things under the covers, so to speak, and understand pain points much more acutely. And one of those pain points was subacute care was largely absent. And subacute care is a wide range of services, but the two things that we focused on were post-acute inpatient rehab and long-term acute care. So, a lot of patients would never leave the hospital. These were largely children with congenital abnormalities that they relied on long-term ventilated care. So ICU level care, which is extremely high touch and extremely expensive and resource heavy. And then the post-acute rehab was not drug rehab, physical medicine. So people who had traumatic brain injury, car accidents, strokes, where there was room for functional improvement and reintegration into society. And so we started there because there was a huge need, a huge gap. At the time, there were a lot of patients in Abu Dhabi that were being sent abroad and parked abroad, away from their families, away from the fabric of that social interaction, away from the love that emanates from human interaction, from home, and on top of that was the immense burden financially, and the government was paying. So you can have a hospital in the UK or in the US taking care of a 10-year-old kid with spinal muscular atrophy, and it would cost the government $3 to $5 million a year, all in, between the expenses of the family, the travel, the hotel, the lodging, and then all of the hospital-related expenses. So there's a very, very strong financial incentive to create a service that was superior to what these patients were experiencing abroad. That was the bar. When we had our conversations with the government, our proposition was, hey, this isn't sustainable, right? We need to bring these patients back to their families, back to society. But more importantly, we need to build those native capabilities. It's a prerequisite to having a well-functioning and evolved healthcare ecosystem. And
what really struck me, though, when I looked at the website of the system you built, is this sense of it having a longer arc, that you're taking care of patients phase by phase.
Correct.
And when you read about continuum of care, it just seems so radically different from what we're used to, very piecemeal. Many people don't even stick with the same doctor for a long period of time, much less have the data over a long period of time. So when you put together this concept of continuum of care and digital health, hybrid health, what is it pointing you to? How is this going to change life for all of us as we experience healthcare?
The ultimate goal is to change how we consume care and how we pay for that consumption. Today, the way that we consume and pay for care in this market is governed entirely by the insurance industry and how they determine reimbursement, right? So, there's two problems with that. One, insurance contracts are only 12 months long. And insurance companies operate under the assumption that next year, that employer who's their client might churn. The Cigna client might move to Aetna, the Aetna client might move to Bupa, and so on and so forth. So it becomes this musical chairs, basically catalyzed by the broker industry, which results in a complete and total fracture of misalignment between those who are paying for the care and those who are ultimately affected, which are the patients and their employers. The employers own the risk. The patients live the risk. Now, when you're an insurance company, and I'll bring this back home to the diabetes space, or actually better, the pre-diabetes space. When you're an insurance company reporting outcomes or reporting against quarterly or annual financial metrics, you don't really, it's sad to say this, you don't really care what happens after 12 months. So you'll be really concerned about managing the heavy patients that cost you a lot this year, but you will have very little interest in identifying pre-diabetics and reversing pre-diabetes. The absolute ROI on that one activity is out of this world. There's some stats I saw out of the US that if you take someone who's on their way to being diabetic and you can prevent that, over their lifetime, there's roughly a $500,000 delta in healthcare expenditures, not including health span and lifespan impact. There's other data, published data, to suggest that, the mere fact of being diabetic will reduce your lifespan by an average of about 6 years. So there's huge socioeconomic impact of managing that one disease. And it starts with prediabetes. I mean, theoretically, if there was a world in which we could identify every single pre-diabetic and then reverse their prediabetes, that you'd turn the curve on diabetes itself. But insurance companies won't pay for that prediabetes reversal journey because they don't see the ROI in the 12-month period where they're doing their numbers.
You took one disease area and have clearly innovated the heck out of it.
Correct.
So what
We went
makes
deep.
And look what's coming out of it. You're really talking about prevention and all the comorbidities that you can just stem just from the very beginning of this process, this disease area.
Yeah.
What makes you optimistic about the adoption and the expansion of hybrid healthcare models across the landscape, across other disease areas? And what are going to be some of the barriers to that?
So the foundational driver pushing all of us towards value-based medicine is the unsustainability of how things currently work. And I've just explained, some of the factors in an insurance-driven context, but even in non-insurance-driven context. Look at the NHS. The NHS is overloaded and at breaking point, if not already past the breaking point. Clearly, what we're doing today doesn't work. There are, as humans, we are more metabolically dysfunctional. So in other words, we're fatter and more diabetic than we've ever been in human history on a per capita basis. And it's getting worse. That's despite decades of innovation, so-called innovation on all of the inputs to healthcare, whether it's the technology that we use, whether it's the drugs that we prescribe, the care models, the beautiful hospitals, the insurance that gives better access. I mean, I say this a lot in other, venues and podcasts, but we've improved everything that's involved in the provision of care, yet our outcomes are increasingly worse. Now, part of that, I don't want to, simplify it too much. Part of that has to consider exogenous forces like nutrition and food and the degree of processed food as a share of total calories that are now part of our children's meals as they grow up. That is an inevitable brick wall. So if you ask me about impediments to breaking through on metabolic health, food is one of them. And sort of the importance of integrating a view on food and regulating food in the same way that we regulate alcohol and tobacco and other things that have a deleterious effect on health. Sugar, arguably, is a worse drug than many things that we consider drugs today. Now, I don't want to get sort of down into the alarmist sugar is evil kind of narrative that comes out of some pockets, but everything has to be within a balanced, holistic view. And ideally, a balanced, holistic view that is clinically based and evidence-backed. And so everything that we endeavor to do at Glucare under metabolic, we publish voraciously. I think we probably publish more than the entire public sector here combined. It's built into the KPIs of our staff. Our physicians have to spend a significant portion of their time doing academic research and publishing that research.
And what are they seeing? I mean, all that data and all that technology, obviously the lifestyle changes are going to pop up, the need to steer to a certain direction. But what is all this data telling you about how we live and what we need to change?
So I'll point you and your listeners to one really interesting study that we did on our own patients. And just for context for listeners that aren't familiar with our model, hybrid healthcare means that we have a physical component and we have a virtual component that go hand in hand. So we've built a center unlike anywhere else that patients do everything in one visit. So we have our own lab, our own pharmacy, there's doctors, diabetes educators, nurses, health coaches, nutritionists, dietitians, there's a master's in sports science. Soon we're adding psychology to the mix. So the entire ecosystem of professionals that a diabetic might need is there in one place. And the diabetic can do all of their testing and all of their analysis and all their engagement with the clinical care team in one visit. It's a long visit, but it's one trip. And they do that one visit.
And with all that data they've collected when they're not in the facility. So they've got that in their hands coming.
Correct. So when they leave the facility, because we've given them an Oura ring, because they might already have an Apple Watch, because we've given them a CGM. And, we've built, I have more engineers on payroll than I have physicians on payroll. We've built an entire customized tech stack to capture all that data and shove it into their medical record, which is, I think we're the first clinic in the world to actually do that in a structured and robust way. But the point is, there is an anchor, which is human, that underscores the journey throughout. And that patient keeps coming back every quarter. And you just don't want to get around that physical examination and that interaction has to happen with diabetics. There are certain elements that can be virtualized. Coaching can largely be virtualized. even some of the follow-up consultations, once the patient is on a good cadence and the follow-up is steady, you can have some of the physician consultations done remotely. But the study that I wanted to highlight, we took our own patients and we cohorted them into two groups. One group of patients who were, we call them the opt-out patients. They had heard that we have a beautiful facility with a nice cafe and good coffee and great doctors. And so they're like, hey, we want to come and we want to see your amazing docs and have the, one visit experience. But we're not really comfortable sharing all our data. And we don't want to download the app and be monitored 24/7. So the big brother thing kind of turned them off a bit. And so we called these patients opt out. They came to the clinic, they saw the same doctors, they used the same protocols, the same drugs, everything was the same. The other category of patients, which is everybody else, is what we call opt-in. And these are the patients that signed up for the remote monitoring piece to varying degrees. We had patients who were super engaged and were food logging all the time and chatting with the coach all the time. And then we had patients who, once in a while might chat, might food log, but they weren't super engaged. But as long as they had even a tiny bit of engagement, we put them in the opt-in category. So we had these two groups. And then we looked at the data. Now, this is a retrospective study, so it's not the most rigorous of scientific analyses, but it's useful nonetheless. The opt-out group, remember, same clinic, same docs, same everything. The opt-out group over the first 3 months had 0 improvement in their HbA1c. The opt-in group, 2.4% reduction in hemoglobin A1c in 3 months, which to us was just mind-blowing because all else is equal except the engagement piece.
The pro-tech patients, the anti-tech patients were on a completely different journey.
I wouldn't call it
Tech
pro-tech,
skeptic.
anti-tech. I would call it engaged, not engaged. So again, I want to steer away from making this a tech story because this is ultimately a human story about human engagement. When you ask patients, what do you love about Glucare? Nobody says, I love the app, okay? And, we're obviously constantly re-engineering our app and so on, but nobody says that. And nor do I ever want them to say, oh my gosh, Glucare, they have the slickest app out there. That's not how we measure success. What do patients talk about? Oh my gosh, I've never had a doctor sit down with me and explain my data in such detail. What a refreshing experience with a physician. I've never understood my own disease in the way that you guys help me understand it. Or they'll say, your coaches are such good accountability partners. They're not pushy, but they help me stay honest.
So then do you see those tech skeptics come online at a certain point? Do they want some of what their other cohort is getting? Because this skepticism or the hesitancy to adopt and jump into one's own data is real. And it's a barrier to the movement of everyone toward the digitization of their own health. So what's the pitch? How do you convince them that this is their way forward?
Yeah, it's a good question. And it's not binary. And it's not a hard sell either. I mean, I'll give you my co-founder's father as an example. 77-year-old Emirati, poorly controlled diabetic. He's been diabetic for over 2 decades. He was a patient at Imperial for all of that time. Well, for a decade, as long as Imperial's existed. And he's never improved. His biomarkers had steadily gotten worse. His HbA1c steadily worse. His pharmacological load, in other words, the amount of drugs he was taking, steadily got more. His weight steadily got heavier. And then when we were building the clinic, he told his son, my co-founder, Dr. Hassan, said, son, I'm really proud of you for taking this on, but I'm an old man. I barely know how to use my iPhone. I'm going to be a terrible patient. And lo and behold, he was a terrible patient. I mean, he barely, the team would try to engage and chat with him. Once in a while, he'd respond. He didn't food log that often, but the mere fact that it was the first time in his life that he had a CGM on, right? And generally speaking, insurance companies don't pay for CGMs for non-insulin dependent diabetics, right? type 1s get CGMs and some type 2s, but we try to put a CGM on everybody, at least for a small period of time, so that they can experience the magic of that data. It's super powerful. So just by virtue of having the CGM on and having the app that allowed him real-time access to that data, it gamified the process of eating for him. He'd pull his phone out under the dinner table after he's eaten something and he'd be like, oh my gosh, that Munsef, that really hit it.
No doubt.
I shouldn't have had that, glass of orange juice on an empty stomach. And so these little micro learnings over time just accumulated into subliminal behavior change. And for the first time in his life, in only 3 months of being with us, his HbA1c dropped by 1.8 points, which is huge. And he reduced his weight by 8 kilos, and we reduced his medication load by 50%.
I think you have a new tagline.
That was a yeah.
The magic of that data. Is what you said. Once you saw the magic of that data, or your new tagline is the magic of that data.
So I would replace one word there. I would replace the word data with agency. And so data is the beginning, but you have to turn data into knowledge. You have to turn knowledge into insight. You have to turn insight into action. And then you have to turn action into outcome. And getting from data to outcome is how we define agency, right? If you think about any aspect of your life, whether it's your professional career, whether you want to become a great cyclist, whether you want to become a proficient pianist, right? There's certain inputs that you have to translate into an outcome, and that's agency. You have control over that. In healthcare, none of us actually have agency. So if I were to ask you, hey, what's the best path to managing metabolic health? It's so hard of a multivariate problem to solve that you would not have any idea where to start.
Well, when you were telling the story, what was going through my head is this person getting better? Very simple. Is this person moving toward health? And so you've really put yourself into the deep on how does this patient get better within the sphere of metabolic health? And now that you've experienced that, where do you see it going next? In terms of scale within this same disease area, across disease areas, are other specialists switched on to building similar models in their field of specialization? What do we see ahead?
Yeah, the future is bright. I'm optimistic. It's not going to be an easy run. And, every day we're hitting brick walls. And so, I've got this invisible bruise right here that you can't see because going up against legacy is hard. It's hard to innovate in healthcare. It's hard to execute. And that's part of the reason why you see a graveyard of digital health companies that have tried to innovate. A lot of that is down to the fact that you really have to understand how every little piece of the ecosystem works in order to manage and mitigate all the various risks. And the biggest one is obviously payer risk, right? So, just to give you an example of how we managed in the early days, we had to go get insurance contracts. We knew that we couldn't go and charge patients cash for these services because there's the expectation that insurance will cover it. So you have to be unburdensome financially on the patient. So we needed insurance contracts. And those negotiations were fish market. That's the nicest way of putting it. And some of the insurance companies got it and were very helpful and cooperative. But the biggest ones, and certainly the biggest one in Abu Dhabi, still isn't in network with us because they just couldn't come around to understanding our care model and reimbursing for it fairly. Half of what we do—
reimbursing for preventive care. Is that
correct?
Right.
Correct. But most of what we do, the insurance companies, they don't pay for it. They only pay for the things that they know how to pay for. So they'll pay for the physician visit. They'll pay for the lab tests. They'll pay for the diagnostic imaging stuff that we do. And they'll pay for the drugs, coaching, nutrition advice, training, PT work. The diabetes educators, sometimes they'll pay for the tech, forget it. The analytics, the, translational medicine piece of taking data and turning, like all of that stuff that I talked about, zero reimbursement for that. So we built a model where for now, and this is literally a temporary business model, we're using our reimbursement rate for the CPT codes that the insurance companies do recognize and do pay for to subsidize all of the other stuff. Now, because we didn't build Glucare as a business, we built Glucare as a lab, as a sandbox to prove that this vision would earn the right to win. We didn't build it to maximize the P&L. If we were motivated, like most private players are, to maximize the P&L, we would simply not do the things that insurance companies don't pay for, which is why every single, endocrinology practice up and down the road doesn't have a nutritionist or an educator or a health coach on payroll. It's why they don't take the time to look at a patient's sleep data, simply because there's no reimbursement for that activity. So the biggest challenge to make this model work at scale is getting people to understand that they shouldn't be paying for care in this way. We should be paying for the outcome itself. If you pay for the outcome and you put appropriate incentives behind the achievement of those outcomes, then you shift the risk entirely to the provider to manage the inputs and the costs most effectively.
As they are well trained to do if they have the tools. They're the ones who could put it together.
Yeah. That's correct. That's correct.
Now, you have made diabetes and metabolic health a positive deviant in terms of the adoption of this kind of technology, the integration of hybrid health. You are really taking this to another plane. And you're doing it here in the UAE, making this ecosystem a positive deviant in terms of what's being done here for diabetes care. How does this go global? How is this going to be something that people can experience in other regions and in other atmospheres where you don't have quite as much foresight? Like here in this region, you have governments who want their populations healthy a generation from now and are thinking about it today. Other governments aren't set up for that in quite the same way. So how does this become the norm for everybody?
It's a great question. And the short answer is there isn't a short answer. We have spent the last year institutionalizing the elements of Glucare and metabolic. So really understanding each of the components of care, because you can deconstruct it and reassemble it in different ways, almost like Lego blocks. So you can dial something up, dial something else down. Now, that might, in fact, change the outcome. So maybe what we've built in Dubai is sort of maximum output platform, right? We've got the GLPs, we've got the CGMs, we've got the data, we've got the tech, we've got the wearables. The first trip that me and Hassan made outside of the UAE for exploration of geographic expansion was actually Kenya. And it was opportunistic. There was a partner in Kenya that was an insurance company that they wanted to bring this model of care out there. And so our first foray out of the region was a market with a very different socioeconomic profile. And so that forced us to challenge ourselves to think about how we could flex this model so that that market could afford the outcome increment, so to speak. If you look at the UK market, which is likely going to be one of our next growth areas, it's very different. You don't have private medical insurance that behaves the same way. Most private medical insurance in the UK doesn't cover chronic care. It covers acute care. And then everyone else is sort of in the NHS swamp, so to speak. So a play in the UK by necessity actually has to start as a direct-to-consumer cash play, which is very different, which means that, okay, you might go to a higher end area where they're more likely to adopt or be early adopters, where they have more disposable outcome. That's not philosophically aligned with where we want to end up. Ideally, we want our methodology and our outcomes to be available to a wide range of socioeconomic populations. So, we are able to flex and tune the model to work in a range of different regulatory, economic, and social contexts. And that's what we're spending most of our time doing now.
And we're hoping to dig into much more of this subject at Abu Dhabi Global Healthcare Week. Thanks for listening to this episode of the HealthBeats podcast. For more healthcare industry news, visit the Abu Dhabi Global Healthcare Week newsletter. The link is in our bio. And if you're interested in meeting me and our guests in person, join us at the Abu Dhabi Global Healthcare Week conference taking place May 13th to 15th at ADNEC Abu Dhabi in the United Arab Emirates. Thanks for listening. You can like, subscribe, and continue to follow HealthBeats by Abu Dhabi Global Healthcare Week for your global healthcare industry digest. See you soon.